بسم الله الرحمن الرحيم وما توفيقي إلا بالله. It gives me a great pleasure to announce for the start of the International Trauma Webinar. After 3 months of continuous hard working, finally it comes live. The International Trauma Webinar with 48 eminent national and international speakers from Egypt, from India, from United Kingdom, and from Ireland, and more than 1,500 dear attendees. First of all, I would like to thank Eva Pharma Company for sponsoring this webinar. And this webinar is under the patronage of the Egyptian Orthopedic Association. And many thanks to Ortho TV channel for live streaming this webinar. Our dear Professor Adil Al-Adawi, the former Minister of Health and Population, and the ex-president of the Egyptian Orthopedic Association, and the president of the Egyptian Medical Association, will announce for the official opening of the day. Please, sir.
Thank you, Dr. Ashab. Hello, everyone. Good morning, good afternoon, good evening, everywhere where you are. Here in Egypt today is the holiday, but the trip of science cannot stop anyhow. And our road in the scientific and academic journey should continue. We have always be grateful for those virtual platforms that allows us to share our knowledge, our experiences, and to meet a lot of friends from all countries and expertise, definitely. Even we are across continents. A lot of benefits we have gained from these virtual meetings. Thank you, Dr. Ashab, our colleague, our active colleague, our active member of the Egyptian Orthopedic Association. He's the Dean of Banha Faculty of Medicine. Thank you for the Egyptian Orthopedic Association. I'd like to welcome all our guest speakers. Definitely, we will initiate a sort of friendship through science for the sake of our junior colleagues, our students, and our patients, definitely. I wish all of you a fruitful conference and productive discussions. Thanks to all of you, and looking to meet again in more and more active webinars. Thanks to all of you.
Thank you so much, sir. Thank you so much. And now we can start our webinar. Our first speaker will be Professor Gamal Hosny, the ex-president of the Egyptian Orthopedic Association and the ex-president of the Asami International and the eminent star in Elizarov and deformity planning. Professor Gamal, please.
Thanks, Mohammed. First of all, I would like to thank Professor Mohammed Al-Ashab, Dean of the Banha University, for the invitation and the great efforts. But also, I would like to send the greetings of Professor Hani Mwafi, the president of the Egyptian Orthopedic Association. He, unfortunately, he couldn't show up in the beginning. Perhaps he was going to join us later on. So I'd like to thank Hani also, Professor Hani Mwafi. I'm going to speak about the close treatment of fractures in adults. This is very unusual. I'm talking about conservative treatment of long bone fractures. Fracture femur, fracture tibia, forearm fractures, fracture humerus. Do you think about close treatment of fractures in adults? It's a new treatment concept which we developed. When we classify the fractures, we classify them into bony injuries and soft tissue injury. This is 100% artificial. This is not true. It's one structure, bone and soft tissues. When the people talk about the bony injury, they always have hundreds of classifications. But when they talk about soft tissue injury, there's only one classification, which dated back to my birthday in 1957 or something like this. So if you want to classify this fracture, if you see an X-ray of this fracture, how would you classify it? Look to the soft tissue injury. It's very difficult to classify the soft tissue injury. Also, when we talk about neglected fracture of the lower limb, we talk about soft tissue interposition, muscle spasm, and bone loss. Remember that the conventional treatment is open reduction and internal fixation. This is double-edged sword. You have a plus, many advantages, but scars, la'na, more soft tissue damage, because you add injury to the already injured bone and soft tissue. So open reduction is a new injury. You add soft tissue injury and bony injury. And people talk about internal fixation, but do they talk about failed internal fixation? Look to this double plating tibial plateau fracture. And we have this 2 centimeter gap in the sagittal plane. When we talk about closed reduction, we talk about closed reduction during the operation on the operating theater, post-operative, or operatively and post-operatively. And this is one of the publications about the closed reduction techniques, if you are intense. We are going to ask 3 questions. Is it possible to do closed reduction of fracture in adults? Can we reduce the fracture without anesthesia, without analgesia? Can we reduce the fractures post-operatively or during follow-up in the outpatient clinic? That means you are in your outpatient clinic, drinking coffee or tea, and you have a displaced fracture. Can you reduce it? What do we mean by closed reduction? We don't mean indirect reduction. This is not true. Closed reduction means without surgical exposure of the fragments, any surgical exposure, not a minimal invasive technique. This is not true. That means moving the neglected fracture from this point to that point without any incision, or from this point to that point without any surgical exposure. Is it reality or fantasy? Can we move this fracture, neglected fracture after 3 months without any incision to this stage? After 1 month, and this is the immediate postoperative. You see displacement, angulation. Can you move from this postoperative to gradual treatment to get this almost anatomic restoration? We always know that if you fail conservative treatment, you go to open reduction internal fixation. We are going to speak about the opposite. If you fail in open reduction, you can do closed reduction. Unlike this tibial plateau fracture, which had been treated by double plating with this lousy reduction, you see 1 or 2 centimeter gap, and the infection, debridement 3 times. Look, closed reduction techniques, using olive wires, using the arched wire techniques to close this gap without incisions. So failure of open reduction means closed reduction. How do you do closed reduction techniques during a follow-up in the outpatient clinic? I mean, you can do coronal translation, sagittal translation, rotational translation, axial distraction lengthening, and axial compression. I'm going to give you an example. This patient presented to us. This is 2 months post-operative. He didn't do a long film. After doing the long film 2 months post-operative, you notice that we have varus deformity. You see varus. When you do the mechanical axis from the center to the center, it lies medial to the center. So we treat the patient as a deformity. We have core, the apex of the deformity, and we put hinges or the ACA and distractor. And we do gradual correction 1 millimeter per day. You see the axis. This is osteotomy rule number 1, and we correct the mechanical axis 1 millimeter per day in the outpatient clinic. Again, soft tissue interposition and translation. This is immediate postoperative X-ray. Comminuted intra-articular, extra-articular after 1.5 months, and this is immediate postoperative. What we do? We do distraction first, then gradual translation from posterior to anterior. You see here, from that point to this point. Took about 1 month. See, this is immediate postoperative. This is gradual correction. You see, gradual correction and overcorrection. after 2 months. Overcorrection to get rid of the soft tissue interposition. Then we treat the fracture as a deformity. We draw the axes and we correct the deformity till we get anatomic reduction. Again, if you have a long-standing film postoperatively in this comminuted fracture, and this is valgus deformity and shortening, we can do gradual correction of the deformity and lengthening from the site of the fracture. We consider the site of the fracture as a corticotomy. So you can do closed reduction operatively, postoperatively, or operatively and postoperatively. I'm going to give you an example or training. This is comminuted intra-articular, extra-articular supracondylar fracture in an old guy. This is 76 years old, diabetic with liver compromise and osteoporotic. We did 3D, and this is in the operating theaters. First of all, we do distraction or manual traction, and we move the fragments. Then we apply the frame to the proximal part, and we use the thumb to manipulate the fragments after drainage or after you aspirate the effusion. Use your thumbs. You see my thumb pushing the fragments. Then you put one wire parallel to the joint, and you build up the frame over this wire, 2 olive wires to compress the interarticular fragments, more wires. You see, this is good, and good reduction. But look to the sagittal plane, lateral, by the image intensifier. This is totally displaced fragments. You have flexion, you have 2 centimeter or 3 centimeter apart. This is totally displaced. And we try to compress, the guys try to compress, you have more displacement. So we do distraction, and after this we use olive wire techniques to close the gap. You see the anterior cortex and posterior cortex, and we ignore the fragments. Anterior cortex and posterior. Using the arched wire techniques. This is the arched wire. Again, with the coronal plane, we still have some sort of displacement. We correct it using olive wires. So this is the final lateral. I look to the long-standing film. After. We treat fractures like deformities. And during follow-up, we noticed that the patient had valgus deformity and 1.5 centimeter shortening. We corrected the valgus deformity 1 millimeter per day, and we did lengthening. And you see immediate wood bearing of the man. 76 years old, diabetic, with liver compromise, osteoporotic. Actually, this is conservative treatment of fractures. Conservative treatment of fractures in adults. If you have a metaphyseal gap, I will show an example what we do. This is comminuted tibial plateau with metaphyseal gap. Look to the soft tissue. They always say you have to wait till healing of this soft tissue. You put external fixator, you put a cast, and within 2 weeks. Who told you that within 2 weeks this is going to heal? This is not true. We took the patient to the operating theater immediately, aspiration of the effusion, and manual distraction. You see my thumbs here. And manual manipulation. We get reduction. You see my thumbs over there. A correction, but we still have a gap. Did the first wire, olive wires opposite each other. You see the lateral, we still have a gap, 6 centimeter gap maybe. You see we still have this gap. What we do, we did acute compression immediately in the operating theater. Acute compression, and waited for 2 weeks. Then we do gradual distraction. You see regaining the reduction, a gradual distraction, you have new bone formation, and this is lengthening. Look to the bone formation in the gap, in the distraction gap. This is how we deal with the bone gaps. See the bone formation. This patient presented to us 4.5 months after the operation. This was the immediate photo after the accident, and this picture after 4 months with a stiff knees, ununited distal femur, and ununited comminuted tibia. We did closed reduction techniques. We used multiple olive wires with the screw traction devices to push this fragment medially from side to side. And we removed this part and put the frame on. And look to the end picture. Complete unit. Again, neglected open fracture, comminuted distal fracture, distal femoral fracture with a bone gap. Look to the soft tissue injury. The bone is protuberant with infection. We did corticotomy first technique. We start the operation, we isolate this part, we do corticotomy. Then we go downwards and muscle flap done by the plastic surgeon, gastrocnemius flap. Then tear. Still, it's under tension. So the plastic surgeon asked us to shorten the gap. So we did angulation about 40 degrees to decrease the gap. Angulation. Then gradual correction, 1 millimeter per day after 3 weeks. We get anatomic reduction. And lengthening from the upper side. See gradual correction. Gradual correction and lengthening. See the distance, about 12 centimeter lengthening. So in conclusion, do you think that we can treat fracture in adults without operation, conservative treatment? Is it basics, myth, or legends? The real merit of closed treatment of fractures is to avoid additional soft tissue injuries. Gradual postoperative reduction during follow-up is possible without anesthesia or analgesia. Soft tissue interposition can be treated by gradual distraction, over-reduction, followed by anatomical reduction and compression. Thank you.
Thank you so much, Professor Gamal, for this very interesting talk. We can allow just 1 or 2 questions after each speaker to just to stick to time. We have one question, Professor Gamal. What are the new serological lab markers for monitoring response to treatment of infected implants besides ESR and C-reactive protein?
But I didn't talk about the infected implants in this series. I didn't talk about them. So I'd rather to let somebody else to answer this question.
Okay. Thank you so much, sir. Now we will move to the next speaker. The next speaker, Professor Gamal, would you please stop your... Thank you so much, sir.
I already done.
Next speaker will be Prof.Medhat Refaat, Professor of Radiology and the ex-head of Radiology Department, Maha University, and one of the eminent stars in radiodiagnosis and radiotherapy in Egypt. Professor Medhat will speak about the impact of MRI in trauma. Professor Medhat.
شكرا جدا معالي العميد.
شكرا جزيلا أستاذنا.
I am so lucky to join the Orthopedic Society in this international webinar. I think it's a great pleasure for me and to have our Prime Minister Dr. Adel Adawi and also the talking with Dr. Prof.Gamal Hosny is an eminent figure in orthopedic. I would like to share now my talk. This one, it will take. So ready now?
Professor, I have shared
started
the presentation.
Yes, sir. It's obvious now, sir. Yes. Next slideshow, please, sir.
It's ready now.
Yes, we can see it.
You can see it already?
Yes, sir.
Okay,
Yes, sir.
Yes.
May you start, please, sir? Just
Yes,
to take
start.
time. Thank you so much.
Yeah, we will talk about the MRI in trauma, which is more beneficial or not. The added value of the MRI in imaging of pathological fracture, we have some objectives. We are looking for that all the lecture about differentiation about the traumatic fracture or from the pathological fracture, which is more in risk factors in also in the management. I already how can now move it. No, it's not responding for that. How can I move? I'm sorry,
The slides are not moving, sir.
it's not moving. Yes, yes, the pathological fracture, which means that there is an abnormal osseous lesion. Fracture pass through this an abnormal osseous lesion. What about the impact of the imaging diagnostic clues? We have fracture line through focal lucent lesion, or fracture in unusual location, or a transverse fracture orientation of a long bone, or surrounding permeative change in the body, in the main bone, or industrial scalloping, or coronoid matrix, osteoid matrix, associated soft tissue mass, and also additional tumor deposits. Again, you can move. Yes. The pathological fracture, there is typical location for that, including the metastasis or the multiple myeloma, which includes the spine, the axial ventricle, vertebrae, the pelvis, the femur, and the humerus. What about the enchondroma, which is beneficial sites for the phalanges of the fingers, and the bone cyst in children? It will be for the long bones and the humerus. There is primary bone neoplasm, benign or malignant or multifocal process. Next, yes. The clinical issue for the primary carcinoma, frequently metastasis to the bone, like breast, like prostate, like lung. The diagnostic checklist, it will be unusual location, as we tell before, the transverse orientation of the trauma, and any fracture pattern in absence of appropriate trauma history, like was called minor trauma. Next, please. Um, we have some radiological findings which will be more clear in the conventional radiograph, like lucent lesion, coronoid matrix, ground glass matrix, surrounding permeative changes along the bone, industrial scalloping, and also associated soft tissue mass. Next. The CT finding have a great role for cortical destruction, for say something about the tumor matrix, the aggressive periostal reaction, and also the industrial scalloping, which we can say before. But the quantitative CT for detection of digital acknowledgement for the bone density can known, but we have a known lesion. What about if we have non-known lesion? Next. Yes. According to the MRI finding, there is factors suggesting pathological fracture. This means that we have multi-planar capabilities for the MRI imaging, like T1, T2, stair, gradient, and more another one sequences which can use for detecting the lesions. Is it pathological or it's only benign fracture? Abnormal muscle signals can be added in the MRI. The soft tissue, it will be more beneficial. The industrial scoping have more than 60% in pathological fractures. All of this, the fracture in related hematoma, which be confused for some radiological evidence like the conventional X-ray or the CT, but the MRI has great capability for detecting and grading the hematoma. Is it acute, subacute, and chronic? The marrow edema, the signal dropped for the phase encoding in MRI, or the infiltrate process along the whole length of the long bones or for the axial vertebral structures. We add for the MRI, which is be more beneficial. This is the diffusion weighted image, which will looking for the water visibility. This is the tumor infiltration marrow, and it will be decreased diffusion. Next. There is Merrill's classification for the management of the fracture, put some points about 1 point, 2 points, and 3 points for according to the site of the fracture. Is it in the upper limb or in the lower limb, or for the trochanteric fracture, which means that we are directly moving for more management, or what's called not waiting for conservative and let and see. Next. About the classification for that, minimum score is 4 and maximum of 12. More than 9% score or 9-point score, this is a prophylactic fixations. For score 8, treatment is based about the clinical judgment. The oversensitivity of this classification, it's more than 90%, but the specificity it's only for 35%, meaning that it will be unnecessary fixations for that patient. Next, please. For some example, about this old man have a fracture history of renal cell carcinoma, so it will be completely for pathological fracture, permeative bony or osseous lesion can be seen along the whole femoral shaft. The score this it will be 11, so fixed, prophylactic fixations dynamic, it will be before complete fracture can be happen for that patient. Next, please. Another type of pathological fracture for metastatic cell carcinoma or mild left-sided leg. Lytic lesion can be early seen in that one, scalloping, and the pathological fracture it's already happened for that one, but it's not comminuted. So substantially transverse orientation for the fracture, which can leave or put a finger that this patient is not benign traumatic. This is only a pathological fracture following metastasis. Next, please. We get now the MRI. The MRI here, we have beneficial first time for the T1, which means we are looking more than the fatty marrow, but only we have here the fatty marrow, it's already interrupted. We have low signal line. We have more than one infiltrative lesion for that fatty marrow. The fatty marrow of the normal one in the femur, it's already changed. The T1 signal here is abnormally poorly defined, patchy area. It's already happening in the femoral neck. Now, cortical disruption, pathological fracture, which will means that one, and another photo for that one is already also the T1, which means we are looking for the fatty marrow infiltration. We have already permeative lesion in another patient, or homogeneous and more definite. Like one, this one is called the weighted not fatty marrow. I have more capabilities for seeing the fatty replacement by another patient like a fracture line, hematoma, or edema. Next, please. This is a clear list for the role of the conventional radiography and the CT for pathological versus stress fractures, where what's more important for us is the MRI, which is we have to say that this is a stress fracture if we have no infiltrative fracture line. It's already absent. It's only one line, low signal, linear diffusibility for that in a background of fatty marrow changes in T1. The adjacent muscle edema for homogeneously low T1 and T2, it will be more beneficial for that edema or the fat replacement by edema or by water-like signal. It will be more seen and benefit for steer weighted image, which means that fat saturation. We already masking all the fat, only the water element it will be appear. Or called in some centers, it's water view. Next. Pathological fracture we have seen here in top of cortical tumor happening. Next, please. We'll show more. Yes. Patient have adenocarcinoma, and we have already for that one is already transverse fracture clearly seen. It's already clearly seen. What we are looking for, the MRI. The MRI, you can see the definite differentiation between the matrix or the fat replacement in the tibial bone in relation to the fibula. Here is the fatty signal in T1, which completely like a fat, like the subcutaneous one in the leg. But here we have abnormal marrow changes in that one with already the presence of the transverse structure. It's already happening that we have what is called you have to think about the pathological fracture, not only benign fracture. Could be a minor trauma happened or without trauma. Next, please. This is another pathological fracture on top of inchondroma, which is happening already in the fingers. We have already mere matrix changes. It's already here for that one. And you can already, the chondroid matrix in the center of the lesion. It's common here, that one, we oblique interarticular fractures with ring finger of the middle finger for that one, the middle phalanges. Next one. Yes, the switching or confirming the diagnosis. We have already here X-ray for the wrist, distal radius, bone, most likely giant cell tumor. If we do the MRI sequences, we have already a changing from giant cell tumor to another one. It's called like a cystic lesion. And we have already more edema-like signal about that one infiltrating. This is the marrow fatty area. Next, please, will show us more. Yes, the initial one is already, as we say, that this is giant cell tumor. But if we applying for the multi-capabilities or multi-sequence or multi-parametric MRI finding, can conclude this is a bone cyst. It's proved to be that one. There is an hematoma, there is tissue reaction to the pathological fracture. It's already seen the extra osseous content. The only impression is non-aggressive lesion remains for that one. Next, please. Yes, for that one was called the osseous tumor does not cause acute pain, but rather than underlying lower level of discomfort. This is very common for the clinical orientation. The patient presenting with symptoms of a fracture, this is an important in helping to sort out the significance of extra soft tissue mass which can be more seen in the cross-sectional imaging like the CT, but less sensitivity, but the MRI is more sensitive and more specific. Next. Another clue for that, the osteomyelitis, the infection, pathological avulsion fracture, the posterior calcaneus for one, and it's already going up with the tendon of Achilles, it's already pushing it out way. You can see the diffuse bright signal in the T2 and T1, and the calcaneus presents for that, and soft tissue changes for the heel of the patient with manifested with osteomyelitis. Next, please. Another pathological fracture, varus angulation for that humerus. The clue is the underlying lesion are well bordered, the cortical destruction. You can see it very clear for that one. Next, please. Another one for pathological cortical fracture for left iliac bones, diffuse bone involvement for that one, enlargement of the bone, which suggests the wideness of that bone, expansile Paget disease. Next, please. This is the lytic lesion for CT with medial femoral condyle, multiple cortical fractures. The attenuation of the lesion is similar to that of the muscles. You can see it. This is proven to be giant cell tumor. Looks like the muscles. It's already in comparison for the digital density for the inside the lesion and also the muscle bulk. Next. What are the general indications for spinal trauma? We have the CT and the radiograph. We can see like ligamentous injury, perivertebral edema, spondylolisthesis, spondyloschitis. But to look for the epidural hematoma, you should do MRI. To identify the spinal cord abnormalities, you should do MRI. To exclude clinically suspected ligamentous or occult bony injuries, you should do MRI. And also to see the stability. You can assess the stability of the cervical spine. You should do MRI. To differentiate between the hemorrhagic and the non-hemorrhagic spinal cord injuries, you should do MRI for prognostic neurological sufficient. Next. We have here single vertebrae affection for one of the dorsal 4, partial collapse, but we have a retropulsed intermediate signal. This is not the normal for that trauma. This is already raising the possibility of pathological fracture. These patients have solitary plasmacytoma and it's already for compressed and already reduced the height, and we have anterior and posterior soft tissue. It changes with intraspinal component. Next, please.
Sir, time, please, sir.
Time, okay. Also, we were remaining the multi-levels for affection for that before the bone marrow replacement, all the whole dorsal spine, the dorsal element, and because of the marrow replacement, acute fractures can be occurred. Next, please. Another pathological fracture for that abnormal bone. The MRI is looking for the abnormal signal, the cortical breakthrough, and additional marks. Next, please. I will be running. It is hematoma or aneoplastic lesions for that region and the pubic bones. Next, please. We already have here the coronal T1 MRI, that is some patient for the X-ray. It's only rarified bone, but we already have here too much hematoma and also some enhancement of the lesion or already in the post-contrast enhancement fat set, which means but the hematoma it's not enhancing. Next, please. Yes, we have already here the lesion at the level of the lesser trochanter in the same patient. Next, please. To summarize, another for pathological fracture from patient from vaginal cancer. The diffusion disability is already here with old diffusion restriction becomes the lesion become more bright, which means that there is no diffusibility. This is packed cells, so means that there is a neoplastic lesion. Next, please. There's another patient for multiple myeloma. You can see that clearly here it's called the ADC, the apparent diffusion coefficient, which means the digitalized photo for the diffusion. We have here restricted diffusion. It's not appear in ADC, which means that completely approved. This is packed cells. Next, please. Yes, we are running. Combining the diffusion imaging for the conventional MRI, increasing the accuracy, increasing the specificity, increasing the sensitivity for differentiation between the normal or benign fracture from pathological fracture. The diffusion imaging protocol, it's very clear, challenging for that one. This recent article will be done. Next, please. There is some altogether some signs for benign origin of spinal fracture, not a single factor, more than one factor. Normal marrow signal, no involvement of posterior element, fluid or gas, low intensity, well-defined fracture line, limited perivertebral soft tissue, preservation of the posterior cortex, non-convex cortex, retropulsed bone fragment can be severely clean, it's not soft tissue, no epidural, no foraminal tissue mass, normal marrow in the whole adjacent vertebral bodies or ribs, anterior wedging, it's not completely collapsed. There is no osteoporotic patient with osteopenia or osteoporotic, and the lack of cervical or high thoracic lesion. This is all together. You can take home message: pathological fracture, unusual location, transverse fracture, absence of appropriate trauma. Tips: metastatic workup, you have to do it. Protocol advice for multiple views in the radiograph. The MRI should have T2, T1 for the fatty infiltration, and the diffusion weighted image, which more raising the sensitivity and the specificity of the imaging. Next. Thank you very much. And this is an old photo from 1891 when are building the bridge for Banha from the Italian engineer. Thank you very much. I am waiting for any question. I am so sorry that I make delay for that lecture.
Not at all, sir. Thank you so much, our dear Professor Medhat Refaat, for this very interesting talk about a very interesting topic, which is the impact of MRI in pathological fractures in trauma. Thank you so much, sir. Now we will start the pediatric trauma session. Our first speaker will be our great professor, Professor أسامة حجازي. Professor أسامة حجازي هو مش محتاج تقديم. Professor أسامة حجازي هو من هو في قمة وقيمة وقامة في علم البيدياتريك orthopedic. It's a great honor to be with us, sir. Thank you so much, sir, for joining us. Professor Osama will speak about evidence of pediatric fractures and range of acceptability. Thank you so much, sir. Please, sir.